welcome, good afternoon, good morning, good evening, depending where everybody is. But we're very thrilled today to have you with us in this session on radiogenomics for virtual biopsy and treatment monitoring in ovarian cancer. So it's three of us today with you. And I'll start introducing myself, and then my colleagues will also introduce themselves. So my name is Evis. I'm a professor of oncological imaging at the University of Cambridge. I also co-lead the Advanced Cancer Imaging Program and the Integrative Cancer Medicine Program for the CRUK Cambridge Center. I am a practicing radiologist, so half of my time I do clinical work, and the other half I do research. And prior to returning to Cambridge, I spent 6 years leading the body imaging service at Memorial Sloan Kettering Cancer Center in New York, where I had a really wonderful experience and brought a lot of experience back to Cambridge. And I'm going to let my colleagues now introduce themselves.
Thank you very much, Evis. So my name is Ramona Woitek, and I'm an academic radiologist working with Evis. Academic radiologist means that part of my time is spent on clinical radiological reporting. I'm mainly seeing breast patients, and I work on their imaging studies, and the rest of the time is dedicated to research. And I'm Austrian, so I did my undergraduate studies and my PhD at the Medical University of Vienna in Austria. That's where I first got in touch with academic radiology, and after I finished training and PhD, I made a big change from neuroimaging to female imaging. And I came to Cambridge in 2017, and almost immediately I started working with Evis on her exciting research projects. And that's also where I met Mireia shortly thereafter. Mireia, please.
Thank you, Ramona. So hi everyone. My name is Mireia Crispin. I am a lecturer in integrated cancer medicine in the Department of Oncology here at the university. And my background is actually in physics. And this is going to be, I think, a bit of a common theme in today's discussion, how in this field of radiogenomics, we have people from all sorts of backgrounds working together to try and get the best possible explanations, the best possible models that can help us understand the complexity of cancer. So my own background was in particle physics. I did lots of data analysis there, and I realized that there were some very powerful methods that could help us to interpret and find patterns in things like images, for example. So after my PhD, which I did at CERN, looking for new supersymmetric particles in the Large Hadron Collider, I decided that I might want to start doing something completely different, such as analyzing medical images, and that's what I started doing. Actually, at Memorial Sloan Kettering as well. This is a bit of a personal anecdote. I was there at the same time as Evis, but never really crossed paths as such. And then we both returned to Cambridge almost at the same time. And pretty much immediately, like Ramona was saying, started working together because we were both interested in the same types of questions. So I came from the computational imaging analysis kind of perspective, but like Evis and like Ramona, my interests also as a physicist were asking, we have such a complex, such a diverse system. How can we integrate everything we know? How can we bring together the different scales from imaging all the way down to the genomics of the disease and make the best decisions for patients? And that's what I do now.
Excellent. So I just want to take from where you mentioned the multidisciplinarity. I think Cambridge is very special, and of course we're biased because we are in Cambridge, but I think I've moved around a lot in my life, and it's great because any place you go, you get new ideas, you meet new people, but it's nothing like Cambridge in terms of creating that multidisciplinary environment. So in no time, I was able to create a group. You know, within 6 months of coming back, we had a group which was so multidisciplinary. It was just amazing that had physicists like Mireia has. Actually, we have 2 particle physicists in our group, and clinicians like Ramona and myself, oncologists, other computer scientists, software engineers, as well as now about 7 PhD students. And not only was the group multidisciplinary, but also it was all along, across the campus. And a lot of our projects are in very close collaboration with the Department of Mathematics and Theoretical Physics in Cambridge, with the engineering department, and with the CRUK Cambridge Institute. So it's really that unique opportunity. You just get on your bicycle and you just, well, not in the COVID time as much, but virtually now. But it was the sense of reaching out to this excellence, and it's everywhere in the campus. That was something that I hadn't felt in other places before, which is so unique to Cambridge. And I think our group has tried to really build on that, and that gets out the best out of people. And we always start from the clinical question, because this is really important, because we don't really want to fit a methodology to a question to a methodology. We really want to sort of answer the unanswered sort of questions. So I'm just going to highlight a few problems or where the challenges are with ovarian cancer, and then I'm going to pass on to Ramona to sort of dwell a little bit more, and then Mireia. So, and the natural question will be, why ovarian cancer? Well, obviously there is expertise in Cambridge, because you always focus on something, there is expertise around you, but also it's really a disease that we haven't made a huge progress in terms of changing the outcome. We are still like we were 20 years ago in terms of overall survival and progression-free survival, and it's a silent killer. And one of the main reasons for that is that we don't really have good methods to really detect treatment resistance early and then adapt the therapy, or really triage patient to surgery versus chemotherapy or neoadjuvant chemotherapy that Ramona will then describe in more detail in a way that is meaningful and really will lead to a better outcome. So here we have the disease which doesn't have any actionable mutation. It's got a chaotic genome, and our ways to actually measure the response to treatment are actually far from perfect. And one of the reasons is because when patients present with ovarian cancer, they unfortunately present with metastatic disease, so already a spread throughout the abdomen. The disease starts at the very end, at the femoral end of the fallopian tube, and then immediately goes to the ovary, so surface of the ovary, and then spreads throughout abdominal cavity in that lining that lines all our organs. So it's metastatic disease. It's difficult to measure and to put a ruler like we do with some of the other more defined sort of tumors, because it's so irregular. It's difficult to really assess the volume of disease in a very accurate way. So this is one of the impetus that we had, and I'll maybe Ramona, you can sort of give us more details into how do you think we've kind of addressed that in our group.
Mm-hmm. So I think the two important questions about advanced ovarian cancer that Evis already touched upon and that we spend a lot of our time working on are, one, how to accurately measure whether a patient is responding to a certain type of treatment. And the other, even more advanced question is whether we can predict how well a patient responds to a certain type of treatment even before the patient started getting any of that treatment. And we use different tools to work on these questions. And as Evis already described, the ovarian cancer is often, unfortunately, it's often diagnosed at a very advanced stage. And we know that for these patients with advanced ovarian cancer, what is probably most important for them is when they undergo surgery, where the different metastases are removed. It's really important that this surgery is done very thoroughly and that all the disease, the cancer deposits or metastases are removed. And for those patients who are diagnosed with lots of metastases, this can be very, very difficult. And that's why a lot of these patients get chemotherapy before they even undergo surgery. And that type of chemotherapy that is given as a first treatment is called neoadjuvant chemotherapy. And the patients usually get this type of treatment for 3 to 6 months before we can see on our images whether the patient benefits from the treatment, whether the patient really responds to the treatment and the metastases and the tumor deposits shrink. So there is a delay of several months before we know whether this treatment with its side effects actually works. And measuring exactly by how much the tumor deposits decrease in size is one of the challenges. So we do very detailed measurements. We outline those metastases in a lot of detail on those images, computed tomography, CT scans that we acquire before treatment and after treatment. That's how we try to develop a method of precise response assessment. But then we go a step further and we try to predict before a patient undergoes that treatment how much the tumor is going to shrink, because we ultimately we would like to avoid patients to undergo this toxic treatment. It is associated with side effects. If a patient is not going to have any benefit from it, because then the most important step is to perform surgery as early as possible. And these are basically the two types of questions we are trying to answer with our imaging research. And as I said, we manually outline those metastases on the images we acquire from our patients to measure the volume. But during the past probably 10 years, a specific new field in imaging research has developed. And that looks into the texture of tumors, of metastases on images that we may not be able to capture just with our bare eyes, but a texture, a pattern of these metastases that is captured by the images, but we need mathematical methods to extract these features, textural features from the images. And by outlining the disease on these images, we can also do some magic that Mireia might be able to explain to capture some of these very detailed features that we can then use to develop tools that help us predict whether a patient is going to benefit from treatment.
If I could just give an example, and I know I'm not projecting an image, but for the ones in the audience that actually love art, if you think the texture is something you can measure anything, if you just can close your eyes and kind of picture a Marosco painting, which is kind of fairly homogeneous, and a Jackson Pollock painting, which is all sort of movement heterogeneous, you can then assign a number. You can actually measure that heterogeneity even in paintings. Now then think when you have a CT, you can measure them on something which is even more sort of very blunt shades of grey. So now off to Mireia.
Perfect, Evis. This is the perfect introduction. I'm going to use this in my presentations from now on. But this is a perfect point to jump in and give actually the more like mathematical explanation, which is not that complex when you think about it, because images are really matrices of points. They're essentially little boxes, little pixels, each of which is assigned an intensity value. So if you look at a CT scan or at any image for that matter, the brighter points will have a higher number, the darker points will have a lower number. And so if what you want to measure is the texture of the image, as Evis was saying, what you want to see is how often certain values of the intensity will appear next to other values of the intensity. So for example, one way that we can quantify the texture of the image is to look at pairs of voxels, at neighboring voxels. And you can decide exactly how you're going to do that. You can decide that you're only going to look at a certain direction. You can decide that you're going to look at all directions. You can look at only nearest voxels or next to nearest voxels, etc., etc. And then you can see how, for example, how different they are to each other. So if you have a voxel that is very, very intense, and its neighbor has very, very low intensity, right? So that the difference is very big. That is telling you that there's a very big contrast in the image. The texture is very likely to be more lumpy, like more Pollock-y, using Evis's example. And you can define all sorts of metrics based on this idea of comparing neighbors. And those metrics are, or can be treated as lists of features that quantify the appearance of that tumor in the same way that you have a measure of its volume, a measure of its diameter. You will also have a measure of its contrast, its entropy, its energy. It's funny because most of these metrics have very physics-sounding names. And use these features to build models that can help you predict how, for example, the patient will respond to neoadjuvant chemotherapy, which is what Ramona was explaining. Now, that is what is called the radiogenomics paradigm. And you can see that it uses the omics ending, which suggests that it's a very large scale type of analysis. And that's absolutely crucial, because the only reason we can do this now and that we weren't able to do it 10 years ago is that now we have access to large data sets, to large amounts of data, to advanced computing. And so we can afford to develop this type of model where we have lots of data, lots of features, etc. And what that means is that we're going towards this kind of, computational imaging paradigm, moving closer to more advanced methods such as deep learning, where more and more we will be able to use the power of computing to understand what is really in front of us in the image and how it relates to the other types of data that we have. Actually, this brings us maybe to one of the key questions, which is how do we bring together the other types of information that we have about the patient? And how do we build these very complex data sets with many patients where we have to put all of these scales together? I don't know if you want to say something from the more clinical point of view, Evis or Ramona, about how we go about this.
Of course. So one thing that I should mention is that you can use any imaging modalities to derive those measures. But what we've concentrated in our group is actually on computed tomography. Why? Because this is what we use in everyday clinical practice. So it's very important that everything you develop, it's actually going to be used as soon as possible, and also with a modality that you use to actually image patients during their treatment, being that in normal clinical practice or in clinical trials. Is of course, you can use on PET-CT and PET-MR, and we have projects doing that more into understanding the biology behind some of these texture features. But CT is our workhorse because CT is used in everyday clinical care. And if we want to make a difference in the next year or so, which we really want to, we have to use the standard of care images. So it's something I should have mentioned at the beginning, really.
And I think to give people an understanding of by how much we extend the amount of data we get from these images. If we think about a routine clinical CT scan that is done on a patient with ovarian cancer to assess how well a patient responds to treatment, if we do that in clinical routine, we will probably see metastases, several metastases. The radiologist looking at those images will measure probably several of them, will maybe measure in 1 or 2 dimensions. And when the radiologist writes a report, some of these measurements will be included. But that's about it when it comes to quantitative information about these images. And if you imagine that and compare it to hundreds hundreds and probably thousands of features that we compute from the outlines of those tumor deposits. That's just a huge contrast, and we were able to show that computing these multiple features it gives us a lot of benefit and helps us a lot in making these predictions regarding how a patient is going to respond to treatment. And we actually did this comparison. We used very basic information that we got from the imaging, but also clinical data about our patients, patient age, also information about the type of treatment and how much treatment, how long the chemotherapy, for how long it was given, things like that. We used a clinical data set to make predictions about how well a patient was going to respond to treatment. Then we added those radiomics features on top, and we found that adding these features improves those predictions tremendously. And then a very interesting other type of data that we include falls into this basket of genomics, and that's about circulating tumor DNA. So we have learned that cancer tumor sheds DNA molecules, short segments of DNA into the bloodstream. And when we take blood samples from patients with ovarian cancer, we can actually detect some of the DNA that comes directly from the tumor in those blood samples. And we were interested how much those radiomics features that we can extract from everyday imaging, how much that improves those predictions compared to adding information about circulating tumor DNA in these patients. And the interesting thing is that radiomics really improved those predictions, and we were surprised to see that they may be equally important to circulating tumor DNA, or maybe even superior to circulating tumor DNA for exactly this type of predictions.
I mean, the other thing to say that we haven't touched is that while it will be impossible on everyday clinical care to actually outline every single lesion manually, because it's labor intensive and it's probably less accurate, because you will need somebody trained for years in looking at CTs of ovarian cancer. In collaboration with the Department of Mathematics, we've developed this algorithm that does auto-segmentation. So the segmentation is done automatically using AI. And then the radiomics sort of features are extracted and the data is integrated. And Mireia can actually give you insights into the deep learning or machine learning algorithms that we're using then to make those predictions.
Yeah, and I think a key idea in everything that we're saying here is that what these methods allow us to do is to treat and look at the disease as a very complex, global entity. So we're not looking at a single biopsy that is extracting a little bit of tissue from, one point in the tumor and using that to make a decision. We're not looking at a single lesion on imaging and looking at a single dimension, a single diameter. We're really looking at the entire three-dimensional complexity of the disease by using imaging, analyzing the quantitative data from every single metastatic lesion in the body by using the automatic segmentation, as Evis was saying, and extracting the radiomics features from every single lesion. We're using circulating tumor DNA, which actually is also a form of global metric that gives us global information about the disease. And I think this is what is so exciting about this type of method. So it's really integration on that sort of scale is the entire information about the patient that we're using. And sorry, I just wanted to make that point because I find it, one of the most exciting things about what we're doing. And then about the computational methods, I think it's great that you mentioned segmentation, because the interesting thing about segmentation is that we can afford to have larger data sets. And I was going to say because we have more information, it's easier to create those, but actually it's not really easy from a manual work point of view, because I mean, you are the radiologists, you are the ones with this incredible expertise to look at the images and know what is in front of you. We, the uninitiated, find it incredibly hard. But here in Cambridge, we have amazing experts in ovarian cancer imaging. And so we've managed to create very large data sets, completely annotated, beautifully contoured, and use those to train complex algorithms. So for segmentation, we are actually using deep learning techniques that are very, very good at finding those contours, at telling us where the tumor is and where the boundary is. For radiomics, we have smaller data sets because there we have to integrate with all the other types of data. We have to have the complete information about the treatment the patient received, the follow-up, et cetera, et cetera. And so the more things that you add to your shopping list in terms of what you need to create the model, the harder it is to create very large data sets. And so there we have to be a bit more conservative with the models that we use. But again, this is what Evis was saying at the beginning. We, of course, want to use the best models out there, but we also want to make sure that what we are creating will be useful for the clinic, that it'll be robust, that it'll be something that you can trust. And so if we have to use a model that is slightly less complex, that is not deep learning, it's machine learning, of the classical sort, but that gives you a result that you can trust and you can understand and you can interpret, then that's what we want to use, because we want to be able to translate that into clinical practice. And
I mean, this is one part of the research into the prediction, prognostication, but the other part is, as we actually started on this journey, you realize that the tumors, especially in ovarian cancer, because there are multiple lesions, you have several levels of heterogeneity. You have in between patients, within the patient, in between metastasis, and also within a lesion. So there are 3 levels. And we know from the molecular studies, from genomic studies, that this underpins the treatment resistance as well because of the clonal evolution. So the other sort of research route we've chosen or endeavor is actually asking ourselves, can we actually use imaging as a virtual biopsy? We can't yet, and we won't in the next 2 years completely replace the biopsy, but can we actually get to the point that, one, our biopsies are more meaningful, are taken from the part of the tumor that perhaps is genomically more unstable, has a higher number of mutations, and maybe when a patient comes back with tumor recurrence, you don't really need to biopsy all the lesions because you really can't, practically. But then you choose the right lesion to biopsy, which will give you the maximum information to then put those patients into a treatment which is really going to lead to a better outcome for them. And we're developing tools to do that via the fusion imaging, and I'm going to let Ramona actually talk about that, and maybe Mireia on the tumor mold, because there are 2 very important pieces of our research.
Yes, so we use 2 different techniques to actually find out why one part of a tumor might look like a Pollock painting, whereas the other part looks like an Eve Klein. One of these techniques are so-called fusion biopsies, and we already mentioned that the imaging technique that we use to measure or quantify the texture, the pattern of a tumor is computed tomography, because this is usually what a patient gets when ovarian cancer is suspected or being diagnosed. And after this computed tomography, we still need tissue. We need a biopsy, a tissue sample that is then analyzed by pathologists to make the diagnosis of ovarian cancer. And what we set up is we take tissue samples from different areas of tumors, and we guide these biopsies by the CT images, and we generate new images that they use color coding, and they basically demonstrate, or they show in a tumor these different areas that are characterized by certain types of texture features or patterns. And a radiologist who then uses ultrasound to guide the biopsy. A biopsy is usually done while the patient is awake. A patient gets local anesthetic injected, and that way tissue samples can be taken. And we are collaborating with Canon Medical Imaging, who are supporting us to actually create a fusion image of the live ultrasound image that is taken in preparation of the biopsy, and those CT-based maps of textural features. We call those tumor areas with particular sets of textural features habitats, and we fuse those habitat maps with the ultrasound images to target our tissue sampling, because we would like to understand why these tumor areas have these very different appearances, Pollock versus Eve Klein. And we need to get tissue samples from these areas. We need to analyze them in detail. We use immunohistochemical staining. We use sequencing techniques to get to the bottom of what causes these appearances. And that's one way of targeting these habitats or different areas. And the second way of targeting those areas are customized 3D printed molds. And Mireia, I think, is going to explain a little bit more in detail how that's done.
Yeah, thank you, Ramona. So the idea is simple. So we've used the fusion biopsies while the tumor was still in the patient. That was the best way to make sure that you could get a sample from a point that you could detect and identify very accurately. But then, of course, there's the second time point, which is once the chemotherapy has ended and the patient has had the surgery and the tumor has been removed, then you actually have the tumor in your hand, so to speak. And so you can section it and obtain samples from anywhere you want, pretty much. You have full access to the tumor. But the critical thing there is that you've lost your anatomical frame of reference. All you have is the tumor. And so it becomes really, really challenging to know what it is that you're looking at. I mean, you can get a vague idea. So, I mean, you know roughly where you are. But if you want to do this perfect matching that Ramona was talking about, if we want to be able to compare the tissue that we have in our hands to the images that we obtained while the tumor was still in the patient, you need perfect alignment. And so to do that, what we do is we design molds that we can put the tumor in with openings, with slots that we can put the knife through. And these slots are not just anywhere. They are in very well-defined places. Because we have all of the information computationally, because the images are completely digital, we can three-dimensionally design the mold and decide where these slots are going to be. And we can create essentially maps for each of these slots of what we expect to see in the tissue from an imaging point of view. So Ramona was talking about habitats, about the fact that we think that these tumors have different regions that are distinct on a biological and imaging level. Basically, what we do is we create these habitats on imaging for each of the slots in the mold. And then when we put the tumor in the mold and cut through, we can directly compare the habitat maps to the tissue sections that we're seeing. And that's on a very basic level. I mean, the reason that we do the 3D molds this way is because it's cheap, it's easy. I didn't say, the way that we create the molds is actually by 3D printing. So it's a fairly straightforward, very automated system that we now do in essentially a few hours from the moment that we get the image to the point that we can have our 3D printer creating this mold that is completely personalized. It's a different one for every patient. And so that allows us to compare tissues to images. But what is really exciting is that we can use computational methods to analyze everything. It's not just this type of basic comparison that I'm talking about now. We can also then go at the tissue and do computational pathology. We can try and understand the tumor microenvironment. And we're doing this also with other members of the team that are looking at different, creating classifiers that will look at a pathology image, identify the different cells, label them, and then characterize the tumor microenvironment. So for example, are there immune cells in the sample? Where are those immune cells with respect to the tumor cells? How are they distributed, etc.? And so we can, again, using computational methods, quantify that microenvironment and compare that directly on a spatial level to the information that we're getting on a macroscopic level from the radiological imaging. So we're directly integrating, again, the idea of integrating, but this time on a scale level, the data that we're obtaining from the different sources of information. And what we're hoping, at this point, everything is very exploratory, but what we're hoping, as Ramona was saying, is that this will help us to understand where this heterogeneity comes from, where this resistance comes from, and what these radiomics features really mean. And that is what will give the power and the strength to the response models that we are creating. But it's a long process, and I think the best is yet to come. Don't you agree?
Absolutely, and I think we are working very hard now to start building our prototypes of using our data integration to actually inform the discussion at the tumor board meeting. If you're in the US, it's called tumor board. In the UK, it's a multidisciplinary team meetings. So we can move away from this sort of aggregated view when you just look at things separately. What did the imaging do, the standard sort of measurement, linear measurements, to actually looking at the global view of the patient with the heterogeneity over time, well, space within the abdomen, but also time. With treatment, we will know where the biopsies are coming from exactly, and then use our integrative work that Ramona and Mireia have done to actually make a better prediction for that patient. Then we can compare that with similar patients. Then we can actually then compare what drug was actually effective in that patient, what can we use in the future. So I know we've got only about 12 minutes and a half, so I really wanted to leave plenty of time for questions. And I think already there are questions from the audience, which is great. And I'm closer to the to the questions, so I'm going to read them out. Well, first of all, is greeting from a fellow from Vienna, Ramona. So, and I think one or two questions I've answered already, or we have answered already, about the methods that we're using, and we said we're concentrating on CT. But of course, we have some work ongoing with PET MRI and actually with carbon-13 as well, which is very sensitive and very quick way. It's a bit more challenging, but we think that it might actually be a tool to detect that really early resistance to treatment. So you have to stay tuned. So next time we'll talk about that. I think it's a very interesting question, and I wanted all of us to chip in. So I'm imagining what environment is necessary so that Mireia can run her work, technical but even financial. With which partners are we working together? So Mireia, do you want to start with that and give your view of sort of how the cancer hospital bring things together? And
yeah, so it's a great question, and I think it's again about integration on multiple levels, but this time integration of people, integration of technologies, of ideas, etc. So Evis already said that within the university, the way we work is there's a cancer center that is a virtual center that runs across the entire university. And that is what brings all of us together, I think, on an academic level. In particular, there is an institute within the cancer center that is called the Integrated Cancer Medicine Institute, And there we have all of us, and we have people from the different schools of the university, from the clinical school, but also the physical sciences, mathematics, from computer science, etc. So we're all working together under the umbrella of integrated cancer medicine and the Cancer Center. It's really exciting that, as Evis mentioned, there's the cancer hospital coming up, and integrated cancer medicine will become a reality within that hospital. So the idea is that there will be a physical space where we are all actually physically working together, because right now it's all virtual. Of course, we meet very often, but I think having that physical space where we can all do this work next to each other and be physically also really close from where the patients are, where the treatments are happening, will enable all of these pipelines that we were talking about, the personalized 3D molds, the personalized treatments, etc. So I think that's going to be a really critical component. And so to get to that point, the key point is, well, it's very good that we have these algorithms and we have these models, but how do we turn them into things that, products that we can use in the clinic? Then we need to move to production. We need to think about challenges that go beyond what is simply an academic question. And to do that, we need industrial partners. And we've been talking to and collaborating with many of them. We've already mentioned Canon Medical Systems, players like Amazon, GE. So we're, there's a lot of people that are interested in this type of work and that we're working with, basically to translate all of this into a product or some kind of methodology that can be used in the clinic in the future. I mean, hopefully that gives you an idea of the ecosystem. I'm sure I'm forgetting things. So Evis, Ramona, do chip in.
No, absolutely. I mean, you've mentioned some of the imaging companies, but of course there'll be ones coming from the genomic side and the pharma.
Absolutely.
So we are trying to sort of work them together. But as Mireia said, we're very good at sort of obtaining that very competitive academic funding, which we all have sleepless nights, and that's what keeps our PhDs going. We've got among us, we've got about 8 to 10 now in the group, and it's amazing because it's fresh blood, great insights. They're just wonderful. But we do need, it's so expensive to actually start having a product then. So there's those collaborations and then others, which we have to probably be better at securing, that will make this then reality, and it wouldn't just remain in a sort of research setting. But the other thing that we are trying hard to do is, not everybody can come to Cambridge to get treated. I think we need to bring Cambridge, or the likes of Cambridge, to the patient. So what we do has to be, our methods have to be translatable and actually applicable down in our network. We cover, for ovarian cancer, an area of over 2 million patients, which don't have access to the same sort of great care or great sort of methods that we are developing. So I think that is important, that we can then translate those back to them. So in a way, sort of, getting our work out to the community and to the patient is very, very, very important. I don't know what any thoughts that you have, Ramona, on that?
Yes, I think the last point you made is a very important one. We already said that computed tomography, CT, is the type of imaging that is most widely used. Algorithms were developed in Cambridge, but they can be applied anywhere, and patients being treated in smaller centers could potentially benefit from our work, and I think this would make a huge impact, or could potentially make a big impact. And also what Mireia described, the work on those 3D printed molds, a collaboration we are currently working on, is demonstrating that patients scanned and diagnosed in a different center, if we get those images, we can work on generating basically the 3D files for printing that mold, and those files can then be sent over to other centers, and if a 3D printer is available there, other centers can actively take part in that research that we are currently working on. So tools that can be integrated into clinical care, but also tools for further research projects can be distributed, and getting support and help with this distribution, I think, is crucial to develop this whole project further.
I mean, the technology is transferable. Actually, we had a milestone sort of just before summer when we, you know, we have a great collaboration with the center in Washington, D.C., with the INNOVA program or Apollo program, and the images were obtained there. The patient obviously was there, and the molds, the files were generated, the radiomics were generated, and the files were generated in Cambridge, and then the whole mold was printed in DC. The whole thing was seamless. To really, we can transfer the technology on other center, and that was across the pond. I mean, it's no reason why it's not done, you know, closer to us. So I think. And I think we also use the strengths of the other places. So that's a center that is very strong in proteomics, for example, is something that, you know, we can benefit from that. So I think we increase our expertise, but also we spread it out, which is actually very important. And
I think one of the things that we're going to need probably quite a lot of support for, funding for, is to create some kind of common framework to educate the next generation of both clinicians and computational researchers, so non-clinical researchers, to work under this idea of data integration. And I think it really requires its own program, you know, a doctoral training program or a master's program, something that really starts to create this new idea of interdisciplinarity and data integration for cancer treatment. And that is going to be a big enterprise. It's one that I am very excited about. It requires a lot of thinking. Nothing has happened yet. That's why I'm saying that, you know, it's probably one of the areas where we're going to require, you know, since you were asking about where we're going to need support, I think this will need a lot of support. So I'll drop it. I'll mention it here, you know, in case anyone has any ideas. I think it'd be something that could definitely do with a lot of help. And it'd be great if Cambridge could be a leader in educating this next generation of clinicians and non-clinicians to work on data integration for cancer.
I mean, it's really interesting. I get asked so often as a radiologist, do you think that the AI and the, you know, that integrative way, it's actually going to replace? And it's a common, you know, question, and actually obviously it isn't, but I think it is going to make it very hard for people who do not, for the newest of clinicians or imagers who do not think in that integrated way. The time of just thinking of certain techniques, it's gone. Now the patient comes with complexity and the patient is integrated anyway. So why are we disintegrating the patient when it comes integrated? So I think that is something we have to really work on. The patient is the center, and we just have to unravel that sort of pathway, and then, you know, maybe unravel and ravel again to actually know more. I think training this workforce is very important. I think our job, no matter what angle we come from, it's just going to be far more interesting. I just wish I was about 20 years younger, and I could have sort of really embraced it then. But, you know, you embrace what you can in life, and then you pass it on. So education is really, really important. I think we just only have just over a minute, but there is a question. Have you identified any genes predisposing women to ovarian cancer? I think it's not going to be a short question to that. We don't sort of, as a group, specialize on that. Of course, we have a lot of strong participation from the ovarian cancer genomics, and, you know, the known ones are the BRCA1 and 2, which also relate to the breast cancer. But ovarian cancer has a chaotic genome and is driven by copy number alteration more than sort of specific genes other than the BRCA genes. But this is something I'm not an expert, none of us is actually a true expert on, but I think we know enough to kind of work on that integrated space. So I think any other last minute question we'll be happy to answer, but I think we've enjoyed this evening very much because it's just wonderful to be able to, I can just picture many people that are listening to us, and I hope we've infused a little bit of enthusiasm. I certainly am over enthusiastic on anything, and it just excites me. It's something I get up in the morning and I just want to carry on and work with people like Mireia, Ramona, our PhDs, our postdocs, and just really, make it better for our patients, right?
Absolutely. Thank you very much, Evis. Thank you, Mireia.
Thank you. Thanks, everyone.